Dr. Ryan Dyess. Dr. Dyess came to us in 2019 as our first endocrinology fellow. He is a graduate of Ross University School of Medicine in the Dominica. He did residency at the University of Tennessee in Chattanooga. While here in fellowship, he has been a stellar learner and clinician. In addition to a variety of medical education efforts that he, in fact, is leading, he also has strong clinical interests, particularly in the areas of diabetes, activity, and exercise. And this makes this topic absolutely perfect. This is his area of interest and an area of research interest as well. And so today he'll be speaking to us about exercise and diabetes, making diabetes sweat. Dr. Dyess.
I appreciate the kind introduction, Dr. Winterhurst. And as you mentioned, I am Ryan Dyess. I am the, second year fellow for Pediatric Endocrinology. A little background on myself first before we get too far along. I have type 1 diabetes. I've had it since I was 9 years old. And growing up with diabetes, I also was extremely interested in sports, exercise, and all things that had to do with being physically active. So when I was growing up, I was on regular and NPH, so there wasn't a whole lot of adjusting. There was also not CGMs, pumps, and all those wonderful things when I was first diagnosed. And we've come so far with that technology, and we've gained so many insights into how to appropriately adjust our insulin regimens and what to do around diabetes and exercise to help mitigate some of the issues that come up, that I wanted to share some of that information and some of the research that I have discovered while preparing for this presentation and on my own. How are you,
Dr.
Kelly?
Dyess?
Yes.
Sorry, is there a way that you can increase your volume on your audio for you a little bit? Your speaker?
Let me see.
Other than that, just, I mean, we can hear, but it's, because you know where we are.
Just not loud?
Yeah.
Kelly, it's loud through the broadcast, so it could be that your speakers need to be turned up.
I've tried to, Jim.
Oh, okay.
Yeah, I mean, I've got them all the way up, and it's all the way up here. Okay.
Let me see if I can.
Well, that's okay. I just don't want to, that's fine. Go ahead and finish. Okay. All right.
Yeah, I unfortunately do not know how to turn myself up, so I hope that everyone else at home at least can turn me up a little bit more. I hope what I'm saying is relevant and interesting to y'all. The next thing to say is I have no financial disclosures. I am a fellow. If anyone has any good idea of how to make me a little bit more money, that would be fantastic. So going over the outline of what we're going to be talking about today, we're just going to be reviewing the basic recommendations from the diabetes associations, illustrate the benefits of exercise, which I'm sure many of us are very aware of. Then we're also going to look at some analysis related to adverse events that can happen during and after exercise, and review some strategies to help prevent those from occurring. And then also kind of at the end, review some motivational strategies and things we can do as clinicians to help increase the amount of exercise that each of our patients is getting in. Additionally, I thought this picture was pretty appropriate as Dr. Winterhurst was reminding us of his Irish heritage earlier at our division meeting this afternoon. I was fortunate enough to get this picture of him working out this past weekend when we were on call together. He wasn't terribly happy just because we were kind of busy at times. So why do we want to exercise? And I think that this opening paragraph from the position statement on physical activity and exercise from the American Diabetes Association kind of sums it up the best. The adoption and maintenance of physical activity are critical foci for blood glucose management and overall health in individuals with diabetes and prediabetes. See more people messing around with things in front of me. In the 1950s, Jocelyn also proposed that exercise is the third essential component in blood glucose regulation for persons with type 1 diabetes after insulin and dietary management. So number 3, after obviously the 2 most important. So looking at a little bit of history, and well before the discovery of insulin and purification, scientists and clinicians realized that type 1 diabetes causes relative muscle atrophy, impaired muscle mass development, and reductions in muscular strength. Dyess had noted right around the time that Christ was born that patients with polyuria were weaker and had smaller muscle mass, but if you prescribed them regular activity, it increased their survival. Additionally, it was also later noted by Aratus, who found that regular exercise improved the disease condition that he referred to as an awkward affection, melting down of the flesh and limbs into urine, and that when those patients exercised, it also improved their disease condition. And then in Toronto, the clinical observations of the first patients given exogenous insulin showed a transformative effect of body growth and development, showing how important it truly was. Fast forwarding to the 21st century, Lee and colleagues published findings in Lancet in 2012 that physical inactivity, so not being active, caused 6 to 10% of the major non-communicable diseases. This would include diabetes. Additional research in the US estimated that inactive people would gain 1.3 to 3.7 years just by becoming active. And then in East Asian population, life expectancy in active people was 2.6 to 4.2 years greater than in inactive individuals. So with all this information, the ADA and other organizations have come out with physical activity guidelines for individuals with diabetes. So reviewing those quickly, adults with diabetes should be have moderate to vigorous activity, at least 150 minutes a week, at least 3 days a week, and there shouldn't be any more than 2 days in between exercise sessions, which will help enhance the insulin action. Additionally, they should be doing resistance training for 2 to 3 times a week and on non-consecutive days. Diabetes is a risk factor for low muscular strength as well. And resistance training can also help in other ways, but interestingly, it can assist in minimizing the risk of exercise-induced hypoglycemia, which we're going to explore in a little bit of depth a little bit later on. Flexibility training and balance training 2 to 3 times a week in older adults. Yoga and Tai Chi may be included if they are interested. And individuals are encouraged to increase their total daily incidental physical activity. So what does that mean? It means take the stairs, don't park right next to the entrance at the grocery store, walk that little extra bit every single day. And then they found that participation in supervised training is recommended over non-supervised programs. Well, let's see how that compares to those with diabetes when they're children. So for children and adolescents, the guidance are really similar, and actually similar to recommendations for all children. The goal is to play 60 minutes a day. So the goal of 60 minutes of moderate to vigorous intensity activity daily, and then doing bone or muscle strengthening activities about 3 days a week, which is similar to the adults, and then decrease sedentary behaviors, just kind of like we were talking about. So all the position statements and guidelines recommend exercise, but why? What are the benefits to the patients? Why are they so excited about exercise? Susan Elusis and colleagues published a manuscript in the Nature Reviews Cardiology in 2018 reviewing the benefits of exercise. This wasn't specific to diabetes, but the benefits abound, which overlap with major comorbidities of diabetes mellitus. Benefits would include that exercise induces anti-atherogenic adaptations in vascular function and structure. Exercise improved cardiac parasympathetic regulation and prevented arrhythmias. Provide cardioprotection against ischemic reperfusion injury. Muscle-derived myokines would promote an anti-inflammatory milieu, as they called it. Exercise can improve the myocardial regenerative capacity. And then loss of muscle mass or strength in general is a risk factor for cardiovascular disease. And obviously, resistance training can help reverse that. And then the last thing that they found is that exercise can promote a healthy gut microbiota and thus protecting the permeability and the function of the gut. In considering the fantastic discussion we had 2 weeks ago regarding diabetes and COVID, I felt it was important to note the association between exercise and respiratory infections. Again, this isn't diabetes specific, but considering what we talked about 2 weeks ago, I think it's very relevant. Ms. Silveira noted that there was lower rates of acute respiratory infection incidence, duration, and intensity of symptoms, as well as decreased mortality from infectious respiratory diseases in individuals who exercise. Jan and colleagues found that exercise decreased the severity of ARDS, or acute respiratory distress syndrome, which is one of the most feared complications of COVID-19, and that a single exercise session could increase the production of antioxidants. Regarding COVID directly, Bronner found that exercise capacity was inversely related to hospitalization for COVID-19, meaning that if you were fitter, there's less chance that you were going to the hospital if you had COVID. And D'Souza found that hospitalization rates due to COVID-19 were decreased by 34.3% in those that were meeting what is the recommendation from the ADA for moderate level activity. Moving on to diabetes specific benefits, the first question someone usually asks is, well, does it help your A1C? Well, McMillan and colleagues helped answer this question by performing a meta-analysis in youth with diabetes and found 11 studies that were suitable for analysis. We'll take a look at that. So they found overall that there was a significant beneficial effect on physical activity on A1C. This forest plot showing the overall estimates of the size of changes in hemoglobin A1C due to physical activity, with physical activity on the left and then the control groups on the right. You can see that most of the plots are on the left-hand side of that. In addition, we found that the benefits to A1Cs were associated with longer programs. So those that were greater than 12 weeks in length, if you're exercising more than 3 days a week, and if you have longer duration of exercise, so greater than 60 minutes a day. Hence why many of the guidelines are the way that they are. Frequency more than 3 times a week. The youth recommendation of playing 60 days or 60 minutes per session. And they also found that combined aerobic and resistance training was also significant. So it seems beneficial for youth in diabetes. How about adults? Well, Zhang and colleagues looked at individuals with type 2 diabetes that had elevations in their blood glucose noted on CGMs in the morning. They had them do fasting exercise before breakfast, and they really had fantastic results. They noticed that there was a decrease in glucose variability throughout the day, better glucose control throughout the day, and a reduced rise in blood glucose after that first breakfast meal as well. So those all sound pretty nice. Additionally, Bond and colleagues found in 2015 that when they performed a large multi-center analysis, that exercise improves basically everything. A1C decreased, although they did find that it only decreased by about 0.5%. So you're not going to take someone from a 10 to a 7 just by exercising. The rates of DKA were less than halved, BMI decreased, and then rates of dyslipidemia, retinopathy, and nephropathy were all less that were exercising. So, just to be timely, published just this month, there was an article that you may have seen come across the Diabetes Smart Brief that looked at the impressive ability of exercise to improve many other factors important to diabetes. They had participants with type 2 divide into both an experimental and a control group. The control group just went about their normal lives, whereas the experimental group participated in 16 weeks of swimming sessions 3 times a week, lasting about 2 hours per session. This study showed similar results that exercise improves basically everything from lipid profiles and glucose levels to blood pressure and BMI, which you can see on that chart on the right. Additionally, Waden and colleagues published results in 2015 of a prospective study that included almost 1,400 patients. They found that physical activity, and in particular intensity, had an impact on the initiation and progression of diabetes-related nephropathy in people with type 1 diabetes. So this Kaplan-Meier curve shows percent who had worsening kidney disease based upon a higher albuminuria class or end-stage renal time or end-stage renal disease over time. I want to draw your attention to graphs B and C because obviously that's where the differences are seen. B shows the intensity of leisure time physical activity. The continuous line represents low intensity activity. The dashed line represents moderate intensity, and the dotted line represents high intensity activity. There's a fairly significant difference there. Plot C shows the frequency of leisure time physical activity, with continuous being less than 1 times a week, dashed line being 1 to 2 times a week, and then the dotted line being greater than 2 times per week. And you can notice that those who are exercising more tend to have less progression of their kidney disease. It is also well established that exercise helps improve mental health in the overall population. Considering the higher incidence of mental health disturbance in individuals with chronic diseases, and in particular diabetes mellitus, Gilani and colleagues in 2019 performed a randomized control trial looking at exercise's effects on mental health in individuals with type 2 diabetes. Their findings weren't surprising, as they found that exercise improved self-esteem, overall mental health, with significant improvements in anxiety, insomnia, as well as physical symptoms relating to pain and other manifestations. So briefly summarizing what we just reviewed, basically, of the benefits of exercise. You can have improved glycemic control, improved hemoglobin A1C, improved cardiovascular benefits, including lung function and cardiac function, which are particularly important to consider in those with diabetes. And there was also significant mental health benefits, which also looked at individuals with diabetes as well. However, whenever we review benefits, you must also consider the adverse effects that can occur with whatever treatment you are using, and in this case, exercise. So, reviewing contraindications to exercise, there are a few true absolute contraindications. However, there are some relative contraindications. For individuals with severe disease, there are some screening that needs to happen. For example, those with chest pain, just like anybody without diabetes, or those with a history of MI or coronary artery disease, should be further investigated before initiating a workout regimen. Additionally, those with diabetes-specific diseases, such as nephropathy, neuropathy, or retinopathy, should also be further screened, possibly with a graded stress test. And those with severe diabetes-related retinopathy, whether it's proliferative or non-proliferative, should probably avoid strenuous exercise. But that's just strenuous exercise. They can still go on walks and get some physical activity to gain those benefits that we talked about before. Additionally, I think it's worth noting that hyperglycemia is not a contraindication. You can exercise if your blood sugar is high. But we should be aware that if you have ketosis, so moderate or large ketones in your urine, and you don't have insulin on board, it certainly could worsen, particularly during strenuous exercise. However, that doesn't mean that if your blood sugar is high, you can't go on a walk to help bring your blood sugar down, which works brilliantly. Additionally, individuals with diabetes must keep in mind that prior episodes of hypoglycemia can blunt a secondary response if you have a second episode of hypoglycemia, which can be seen more frequently during exercise, which we're going to review next. So, exercise and hypoglycemia. When, why, and how to mitigate it. So a little background. Dragona and colleagues found that the total time of physical activity in those with diabetes was on average about 24 minutes lower than their healthy peers. Why? Well, Brazeau, as well as Pinkser, had at least partially answered this question by providing a questionnaire and an online survey, respectively, pertaining to the barriers of exercise in type 1 diabetes patients who were adults. Their findings were that the fear of hypoglycemia was the strongest barrier to meeting those exercise guideline goals. So our patients have fears surrounding hypoglycemia and exercise, but are those founded with data? In short, yes. At least for stage 1, stage 2 hypoglycemia, but maybe not severe DKA or severe hypoglycemia requiring assistance. Kanzi and colleagues with the Diabetes Research Children's Network in 2008 found that youth with type 1 diabetes who underwent prolonged moderate aerobic exercise resulted in consistent reduction in glucose and frequent hypoglycemia when pre-exercise glucose concentrations were less than 120. Further, they found that treatment with 15 grams of oral glucose was also usually insufficient to reliably treat hypoglycemia while these patients were continuing to exercise. Additionally, they found that aerobic exercise sometimes can produce nocturnal hypoglycemia overnight that must also be treated. However, Bond and colleagues in a cross-sectional multi-center analysis of a little over 8,000 adults with type 1 diabetes found that there wasn't an increase in severe hypoglycemia that required assistance in those that were physically active. However, looking a little further at that data, there are some individuals that we do need to be more aware of. For example, on this particular graph, the dark bars represent those that are inactive, the white bar represents those that are active 1 to 2 times per week, and the striped represents those that are active more than 2 times per week. In the entire study population, there isn't a great difference. However, if you note those that are 45 and older, there seems to be a pretty large difference between those that were inactive and those that were being more active than those. Additionally, there was a difference between the women's group, which is interesting because I don't quite understand why that would be. Regardless, something that we should keep in mind when we're talking to these specific aged individuals about their risks of hypoglycemia. So, why does this occur? A quick review of physiology. I don't want to get too far into depth, but the increased blood flow to muscles and increased GLUT4 non-insulin mediated glucose transport helps increase the glucose uptake into the muscles, which thus decreases your plasma glucose. And then, via the beta cells, you'll decrease your insulin, and thus increase your counter-regulatory hormones, and thus you'll have normal glycemia. This is for the non-diabetes related individual. However, in those that have diabetes and are on insulin, you have that same glucose uptake, that same fall in glucose, but you can't turn off the insulin. Beta cells aren't working. So your counter-regulatory hormones can't increase quite as much, and thus you end up with hypoglycemia. Additionally, to that physiology, it seems that rapid-acting insulin may also be absorbed faster in times of exercise. In this past year, Pitt and colleagues published a manuscript that reviewed studies looking at insulin absorption rates in relation to exercise. They concluded that there was evidence to suggest that location and depth caused additional variability to absorption rates of the rapid-acting insulin. They found that if you gave a deeper injection, you had a higher rate of absorption. If you were doing exercise that was local to the muscle or the subcutaneous tissue that was being exercised, there was a higher rate. So for example, if you were going running and gave your injection in your thigh, but that local and ambient temperature also increased with higher temperatures, your absorption, or decreased if you had a lower temperature. Therefore, swimming in a cooler pool may actually decrease the absorption rate. However, it's worth noting that Peter and colleagues found no significant difference in iodine 125 labeled insulin glargine decay rate comparing exercise to rest days. There was still a significant fall in plasma glucose, but the insulin levels didn't significantly change between exercise or rest days. They summarized this is likely due to the relative insulin excess or possibly other factors. We've seen that hypoglycemia can occur with exercise. What can we do about it? First, we can try timing our exercise and reducing our insulin. Valley and colleagues in 2020 found a reduced risk of hypoglycemia if exercise is performed in the morning rather than in the afternoon. And if they did a 50% decrease in their rapid-acting insulin. So half your bolus and exercise in the morning, there was less hypoglycemia. Additionally, Moser and colleagues found in a randomized crossover study that looked at glycemia in individuals who exercised for 5 days, then they had a washout of about 4 weeks, and then they worked out for another 5 days. The crossover was either a 25% reduction in Tresiba or their full insulin, and then they just reversed the groups 4 weeks later. They similarly found that there was more time spent in euglycemia when you decrease the Tresiba by 25% in those that were being active. This was found similarly a few years earlier by Campbell and colleagues who reduced basal rates by 20% in their study with similar findings. However, they didn't mention which long-acting insulin they were using. They just said the basal insulin. So reducing long-acting insulin seems to help. How about for those on pumps? Those and colleagues found that when they studied 38 participants with type 1 diabetes who crossed the Samaria Gorge, which is actually the second largest gorge in Europe, that pump users had a lower number of hypoglycemia events and had a very better area under the curve than those that were using injections. However, nocturnal hypoglycemia continued to be an issue with both groups. Brunk and colleagues looked at a post-lunch afternoon exercise, since not all people, including myself, are willing to work out first thing in the morning. I just can't really get my muscles working at that time. They just don't act. They reviewed the percent reduction at different times prior to exercise for pump users. They had participants come in for multiple sessions, both for a session 3 hours after lunch and for sessions that were 90 minutes after lunch on a few different occasions. They found that the group that exercised 3 hours after lunch, if they reduced their basal rate by 80% or stopped the pump for the moderate or intense exercise, performed better, had less hypoglycemia. However, the group that exercised 90 minutes after the meal needed a decrease in their bolus of insulin by 30 to 50%, and no decrease in the basal rate was needed at that point. How about closed loops? There's been several recent articles that I briefly reviewed that all showed a decrease in nocturnal hypoglycemia after exercise when people were using the closed loop systems. These systems also improve time and range, which I think we all are pretty aware of at this point. Hyatt and colleagues used a closed loop system showing these results that if you exercised, or they had them exercise twice a day, and they had an improved time and range, and they had less nocturnal hypoglycemia, which is fantastic because you don't want to go low in the middle of the night, particularly for our children. The next group used a closed loop system, used a threshold suspend system at a 1-week sports camp. Using a threshold suspend, they had to take less carbohydrates in to maintain euglycemia. So those that weren't on a threshold suspend seemed to have to eat a lot more carbohydrates to ensure that they didn't continue to have hypoglycemia. And then Breton and colleagues in 2017 recruited people to a 5-day ski camp in Werner Green, Virginia, as well as Breckenridge, Colorado. They found that the closed-loop system reduced exposure to hypoglycemia both during the day as well as overnight. The last question I had about that study is, how can I get recruited to go skiing for 5 days and people just look at my diabetes? Because I'm into that type of thing. Lastly, let's look at some non-insulin strategies to help reduce hypoglycemia. Yardley and colleagues had individuals with type 1 diabetes perform either 45 minutes of aerobic exercise followed by 45 minutes of resistance training, or vice versa, and did 45 minutes of resistance training followed by 45 minutes of aerobic exercise. In this graph, the solid line represents the blood glucose group that performed resistance before aerobic exercise, whereas the dashed line represents the glucose of the group that did aerobic exercise first, then followed by resistance. As you can see, performing resistance first, followed by the aerobic activity, improved glycemic stability throughout exercise and actually reduced hypoglycemia as well as post-exercise hyperglycemia in these individuals with type 1 diabetes. All that being said, Riddle and colleagues published a fantastic review article in regards to exercise management in those with type 1 diabetes. This decision tree from their article helps summarize how to diminish the risk of hypoglycemia during exercise. I would encourage everybody to take a look at that if you ever have any questions. It was published in Lancet Diabetes Endocrinology in 2017. Basically, it goes through and says at the start, are you eating or are you having bolus insulin on board or not? If you have bolus insulin on board, you need to go this way and say, can the bolus insulin be reduced? If it can't, you need to eat carbohydrates. They recommend anywhere between 0.5 gram to 1 gram per kilogram of body mass per hour of activity. Therefore, they're recommending for an individual like myself who weighs over 100 kilograms, if I was going to do 1 per kilo for 2 hours of activity, then I need to eat 200 grams of carbohydrates. That's more grams of carbohydrates than I eat during the entire day, which is a lot. If you can reduce it anywhere between 25 to 75% based on each individual user, as well as how hard they're going to be exercising. Maybe a 25% reduction for light exercise, 50% for moderate, and 75% for high intensity. Going the other way, if you're not going to have any insulin on board, can you reduce your basal rate? Are you on a pump? If so, they recommend decreasing your insulin by anywhere between 50 to 80% up to 90 minutes before the start of exercise. So I guess that would also include turning on exercise mode on your smart pumps. Or you can consider completely suspending your pump at the start of exercise. If you're going to do that, you may also need to consume some additional carbohydrates at the very beginning due to that additional relative hyperinsulinemia. Additionally, if you cannot reduce, you need to eat additional carbohydrates and consider a 20% reduction in your basal rate if you're not on a pump. Additionally, to try and counteract that nocturnal hypoglycemia, they recommended people continue to decrease their boluses by up to 50% to reduce that risk of nocturnal hypoglycemia. There's a lot of other things that we also need to talk about in relation to diabetes and exercise. Hyperglycemia can occur, usually more common in type 1 diabetes, and usually actually occurs because people are overdoing it on the reductions in insulin or overdoing it on the consumption of carbohydrates. For example, if I ate 200 grams. However, Marlies and colleagues also published research in 2002 that showed increases in adrenergic responses were responsible for the rises in blood glucose, both during heavy lifting as well as intense exercise. Gallicetti and colleagues in 2013 described this adrenergic response as also being responsible for what's called the game day phenomenon, in which athletes on game days, or days that they are going to be really performing, are more stressed, more excited, and probably having a higher adrenergic response as opposed to on practice days when they may have actually experienced hypoglycemia and continue to reduce their insulin. Another question is, are patients with diabetes weaker than their peers? Does diabetes affect their performance? Anderson and colleagues enrolled patients with type 1 diabetes to a hyperglycemic clamp study. They had them perform exercises both during euglycemia as well as hyperglycemia. They found that after a few hours of hyperglycemia, that led to a reduction in isometric muscle performance. However, it seemed like isokinetic muscle strength was unchanged. Reduction in muscle strength could explain why some individuals with type 1 diabetes complain of fatigue due to elevated blood sugars while they're exercising. Well, it seems like hyperglycemia may affect at least isometric strength. How about hypoglycemia? Well, Kelly and colleagues studied youth attending a sports camp. They carried out multiple skill-based tests, including tennis skills, basketball skills, soccer skills, with glucose monitoring over 4 days. Overall, sports performance skill was approximately 20% lower in individuals when their blood glucose concentration was in the hypoglycemia range. Nocturnal hypoglycemia was also noted to be present in 2/3 of these subjects, but they determined that this did not affect their sports skill performance the following day. So if someone has a low blood sugar the night before, they should be okay, at least performance-wise, the following day. But we still need to keep in mind that they may have a blunted response to another episode of hypoglycemia. However, you may not want to tell that to these guys. In this study, they followed 10 athletes with type 1 diabetes for 3 years, during which each one of the 3 years they did a triathlon. In that study, the performance of those with diabetes equaled those of age-matched healthy athletes. Double participants experienced hyperglycemia during the early portion of the bike leg, whereas all of them developed low blood glucose levels during the marathon leg, where they were, running. So in summary, does diabetes affect performance? Possibly, yes. But with adequate training and optimized blood glucose, individuals with diabetes can achieve results similar to their peers. A couple other possible effects of exercising with diabetes are impaired heat dissipation as well as orthopedic injuries. Pajat and colleagues looked at heat-related consultations amongst individuals with diabetes and found that although there was a limited statistical power to detect interactions, people with diabetes who also had cardiovascular or respiratory comorbidities did have an elevated risk of heat-related consultation in the hospital. Additionally, Carter and colleagues looked at heat loss responses using skin blood flow monitoring as well as sweating during high-intensity exercise. and found that individuals with type 1 diabetes had impairments in heat dissipation during exercise in the heat. Thus, individuals with diabetes exercising in the heat may either want to wait until it's a little bit cooler or find some area that has air conditioning to ensure that they don't overheat. As for orthopedic-related concerns, Wong and colleagues looked at load response behavior of tendons that they theorized would be altered in type 1 diabetes as hyperglycemia can accelerate collagen cross-linking. Their findings actually did not suggest individuals with type 1 diabetes were at increased risk of tendon injury. However, Ranger in that same year did a meta-analysis looking at the prevalence of tendinopathy in individuals with diabetes. They found that tendinopathy was more prevalent in people with diabetes. Diabetes was more prevalent in people with tendinopathy. And people with diabetes and tendinopathy tended to have a longer duration of diabetes than people with diabetes alone without tendinopathy. They also noted that people with diabetes had thicker tendons than their controls as well. So there may be some increased risk for tendon injury or tendinopathy, but not all the data is in agreement. However, it may be worth noting to our patients that stretching both prior and after exercise may be important to prevent an injury. So now I want to review kind of at the end here some motivation and trying to get our patients to exercise, because we reviewed all the amazing benefits and how to mitigate some of the poor effects like of hypoglycemia, but we still need to get our patients to get up and move. So in the case of diabetes and exercise, quite literally, knowledge is power. And although there is formidable evidence regarding the benefits of exercise in persons with diabetes, several studies have shown that there's minimal number of healthcare providers actually counsel their patients about exercise. For example, Barnes and colleagues found that only 32% of patients acknowledged that they were given any sort of physical activity counseling during the entire past year at their appointment with their healthcare providers. Considering one barrier to exercise is lack of knowledge and how to exercise safely and appropriately, dispensing this knowledge will likely improve upon the lack of exercise confidence in those with diabetes. Thus, if it's important for us to provide education to our parents or patients, do we need to increase our own personal knowledge about exercise? I can only speak personally about my experiences in medical school, and I'm unsure about your guys' training. However, at my medical school and residency, there lacked a dedicated curriculum committed to exercise prescription and education. It might have been half an hour worth of lectures. However, if we as clinicians are not as comfortable because we haven't had the adequate training and education about this, it may be warranted to employ the knowledge of a specialist, like a certified exercise physiologist, who that is quite literally what they do, and their job is how to exercise and how to exercise safely. Additionally, Lobello and colleagues found compelling evidence that doctors' health matters and that doctors' personal physical activity practices influence their clinical attitudes and practices towards physical activity. They found that there was a strong association that was independent of demographic, training, and clinical practice factors. Therefore, during all the benefits of exercise, I hope that each of us, if we can take one thing from this, is that we should be exercising more, because it may lead us to talk to our patients about exercise more as well. Lastly, Asante and colleagues and Littlegaard and colleagues noted that if you work out with a friend or being physical with a friend, you are more likely to stay adherent to your exercise program. So we can encourage our patients to find an exercise buddy. Do a half marathon with a friend. So some parting considerations and kind of a summary. Exercise is a key component to diabetes management and complication prevention. Exercise frequently can cause hypoglycemia, but this can be mitigated by using insulin adjustments, doing resistance training prior to aerobic activity, using smart technology like pumps and the closed loop systems, or possibly, if you need to, eating. Although for many of our patients who may be trying to work out to maybe lose a couple of extra pounds, that may not be the first choice that they have. People with diabetes may be at increased risk of orthopedic injuries and overheating. But remember that we want to incorporate exercise education into our patient visits, and if we don't feel comfortable, ask for help. There's nothing wrong with that. Remember that all people with diabetes are different. They may have a different response to different types of activity. Each person's going to have a different fitness level and a different comfort with their glucose control. They're going to have a different tolerance for higher blood sugars and lower blood sugars. So remember, we need to tailor diabetes to meet exercise needs, and that may be required through trial and error. And then last, but maybe not least, I wanted to go over some of the celebrities that have diabetes or type 1 diabetes. And diabetes doesn't seem to hold them back from anything that they do. This is Adam Duvall. He's a Major League Baseball player, an outfielder, and he was actually born here in Louisville. Sarah Groenwegner, she's an Olympic softball pitcher from Canada. This is Mark Andrews. He's an active NFL tight end playing for the Ravens, who Lamar Jackson also plays for. He actually recently was talking about his diagnosis and growing up with diabetes and being active as well. Jay Cutler, who's an NFL quarterback, who I used to joke with my friends whenever he would throw an errant pass. I think his blood sugar is low. I don't think I'll ever know whether it actually was, though. Antonia Gorason, she is a soccer winger for Sweden, I believe. Adam Morrison, he was an NBA small forward, but that's not the picture that's up there. That's Wasim Akram, who's actually a world-renowned cricket bowler from Pakistan. This is Kelly Kooning, who is an LPGA golfer, and if you notice, there's something on her back pocket there that many of us may recognize. And lastly, there's Robin Arzon, who is actually an ultra-marathoner and a cyclist, and actually she's the VP of Fitness Programming and an instructor at Peloton. You can see she also has a certain device on her arm. Finishes up my talk. I have a lot of references, but I know what you all are really waiting for is today's event code. Happy St. Patrick's Day, everyone. I'm willing to try and answer any questions that you guys may have. Yeah.
Questions are in the chat session.
Let's see if I can find the chat.
So while you're looking at the chat, Ryan, thank you so much. That was a wonderful, great review. It was awesome. As we start spring. Oh, okay. Oh, he has to do it, right? Which is fine. I'm asking questions. Yeah. Are you able to hear me, Ryan?
I am.
Okay. So I had a couple of questions. So one of the things you should do is stop sharing your screen to go to the chat box. Malika just reminded me.
Thank you.
Yeah.
I was trying
so
to
I
figure
forgot
out
that because usually we do it from here. So I had a couple of questions. One is, you used St. Patrick's with the weight, and I was using the green donuts this afternoon for a thyroid talk. So that shows the difference. So the one question I had was in the adults, especially, many of our closer to geriatric patients that we see who do use the CGM technology and everything. One of the things I noticed with the sarcopenia and all that is this study, Yardley study that you showed with the resistance first followed by aerobic, which seems to be the right way to do. I still see a lot of the hyperadrenergic response with that. So are there any suggestions or anything about that in older adults? I know it's easier to track it in the younger children or adolescents with sports, contact sports and all that. So is there any suggestions for that?
For tracking glucoses during activity?
Yeah. No, not tracking, but many of them do have some sarcopenia, right? Elderly patients who try to exercise. I have noticed that there's the adrenergic response is there in spite of trying to do resistance followed by aerobic, which is the recommended way to do to avoid hypoglycemia.
Yeah,
right?
absolutely. So some of that additional hyperglycemic response may be due to additional lactate that's building up in the muscles as well. So that's another thing to consider, and that as they continue to work out and get stronger, that may not occur quite as much. And in some of the studies regarding resistance training, sometimes people actually did need to give themselves a small bolus to help prevent that hyperglycemic rise.
Yeah.
But obviously, that would require a little bit of trial and error and adjustment and being careful about it, because obviously exercise could make you go low as well.
That's right, yeah. And in fact, I remember one of Ann Peters' talk. I think she showed the race car driver, I keep forgetting his name, the one who she used the pump on, the closed loop, I think, a few years ago. So she had suggested, which you had alluded to, about the 12-hour extended hypoglycemia, which could, when you exercise midday, you could still go hypoglycemic late in the night. So that's another thing which is smart technology, especially with the newer pumps with the exercise mode, sleep mode, that you're able to adjust that. So that is very helpful.
It should be noted that for individuals that aren't on the smart technology, looking at decreasing that the boluses later on can help prevent some of that as well. Or if they're not worried about weight and they're exercising just to be healthy in general, having a good protein-filled snack before going to bed can help mitigate that as well. And honestly, that's what we used to do back in the day when I was on regular and MPH. It was I went to bed every night and I had some peanut butter and some whole milk just to kind of help make sure I didn't go low in the middle of the night.
Thank you very much. I'll let you answer other questions.
Yeah, I was going to take a look at these chat questions. Let's see. So any link between exercise and healthy lifestyle, including a balanced diet with optimal protein intake prior to getting COVID and fatality rate? There may be, but I did not see any of that particular data out there. That doesn't mean that it necessarily doesn't exist. I just have not physically looked at it. Is there any difference between the benefits of outdoor exercise with exposure to sunshine and indoor exercise? Well, in relation to diabetes, I didn't see anything related to that. However, adequate vitamin D does have an association with muscular strength as well as recovery time. So getting a little bit of that extra vitamin D from outdoor exercise may help improve muscular strength and your recovery as well, but nothing in particular to diabetes specific that I am aware of. The last one. Any additional benefits from hot sauna plus exercise? So I guess I would answer that by saying that stretching, exercising, and increasing just kind of movement in general, whether that's doing Tai Chi, yoga, using a muscle massager, getting massage for exercise, can give you additional recovery benefits and help continue to increase muscle mass. But again, diabetes related, I didn't see anything. And in particular, hot air sauna, you may have low blood sugars if you're hanging out in a hot air sauna for too long, as we saw with that one study in heat, kind of increasing the amount of insulin absorption. Let's see. Long-term fatigue. Do you recommend? Okay, long-term fatigue following COVID clearance is common complaint of those who had COVID. Do you recommend vigorous exercise to such recovering patients or a slow exercise routine? So I think it's increase as tolerated, and that should be said for really anybody that is undergoing any form of exercise, and particularly for those that may have some mild contraindications. Increase slowly, continue to build up that endurance as possible. I don't know of any specific data in regards to long-term COVID and the vigorous exercise versus slow exercise, and I don't know that that data is even available yet. However, when you're recovering from something, you don't want to overpush yourself because you may induce an exercise-related injury, which is exactly what you would not want to have, because then you can't exercise anymore. And the last question that was in the chat, is there a link between exercise-generated endorphins and glucose control? I didn't see anything particularly mentioning endorphins, but again, there was the adrenergic response and that increasing hyperglycemia or increasing your glucose. But I would imagine, as we've seen, the endorphins, or at least from what I've always been told, the endorphins can help make you happier. And exercise is related to increased benefits for mental health and less depression as well. So certainly something that seems like there would be a good link there. I think that's all the questions from the chat. Were there other questions from maybe those at home or people in the audience?
Yeah, I'll ask you a question. Hi, Steve Winters here. How are you? So I received, you showed us someone wearing a device. So to what extent has closed loop devices been used? And for example, boys playing basketball in the summer camp, what kind of radical changes and improvements do these closed loop devices provide? And I suspect there's a lot of skill in how you adjust these devices in the context of vigorous exercise, bike riding, basketball, those kind of things. Tell us a little bit about your experience there.
So I guess my personal experience and looking at a true research or well-done research is difficult, because a lot of these closed-loop systems are, just about a year old, or with the Medtronic system, it's a little bit more than that. But in my personal experience, putting on that exercise mode can actually make a pretty big difference, because you're setting your threshold for suspend just that little bit higher. Additionally, by decreasing bolus amounts, so by decreasing it by about 50% is what I usually do when I'm doing a moderate to vigorous exercise activity, it does make a huge amount of difference. And I usually won't have a hypoglycemia that is, to a level 2. I may have a mild one down into the 60s, but certainly makes things much better. Additionally, I think the biggest thing that the closed loop technologies have had an effect on, which I showed several studies about, was the nocturnal hypoglycemia, and the fact that those threshold suspends in the closed loop systems, by decreasing the amount of insulin that these kids are getting, is actually decreasing the amount of time of hypoglycemia overnight, which I think is really the scariest time to have hypoglycemia, at least for many of our youth.
Brian, thank you very much. That was really wonderful, and that's great inspiration you are for your patients. So I just wanted to add one more comment, not really a question, and that's more for the adults. With the exercise initiation and everything, one thing I always make sure is do a bone density screening with the higher risk of low bone mass, in especially our type 1 as well as type 2, and make sure they're not a fall risk or anything, because there was one study looking at hip fractures, higher risk in dog walkers with osteoporosis. So that's the only comment I had. Otherwise, it was a great overview. Thank you.
Thank you. Everybody have a great St. Patrick's Day.
You too. Thank you.